play something, a video clip or something?
Yes, yes.
I've also changed my location today.
Oh,
Yeah, last week when normally said it was they're saying that I've got a poor network connectivity. So we tried. So I'm trying this site for the first time. Did I go grab myself a cup of coffee quickly? Sure. You all said come. Are you going to play the video? Oh, nice. Oh, nice. Thanks a lot, Dr. Ndwambi, for that nice video clip. It's a first for us that we get a speaker to do that for us. And it's exciting to be back once more with colleagues as we continue with our Clinics Health Group weekly webinars. We've been doing this for the past 2.5 years now, I think. And it's good to have you back and welcome everyone. And we welcome also those who might be joining us for the first time. My name is Raymond Bila and I work for Clinics Health Group. And we are hosting these webinars on YouTube streaming live on YouTube this evening, as every week. And the request that when you log in, please do make sure that you give us your full details, your registration number, whether with the HPCSA or the Nursing Council or the Pharmacy Council or any other group, allied health professions council, and your contact details, email, so that it is when the HP, the regulatory bodies, when they upload your details, they can send them your CPD points via email back to you. I know that some colleagues have complained that they've not been able to get the CPD points. So we request that please, when you do submit information, do make sure that you give us a correct email address. And this evening, we are excited to have one of our own from Clinics Health Group, Dr. Phumudzo Ndwambi, who is the general surgeon, whose special interest is in breast surgery and expertise in Oncoplastic surgery. And there's an MBCHB from UCT and a FCS from College of Surgeons, College of Medicine of South Africa, and MED from Vets University. As I said, she's a general surgeon with a special interest in breast surgery, and she has obtained MBCHB with those universities and the college as indicated, and gained experience from the Western General Hospital in Edinburgh to the Royal College of Surgeons. And Dr. Ndwambi is currently practicing as a general surgeon and has special interest in breast surgery at Butselong Empilweni Private Hospital, our first ever clinics hospital based in Vosloorus in Ekurhuleni. So we're excited to have you with us this evening, Dr. Ndwambi, and we'll look forward to an engaging and learning experience as we learn about breast surgery. Thank you very much and welcome to our weekly webinars.
Thank you so much for having me. I'm very excited. Shall we begin?
Oh, we are on the roll.
Okay, I'm just going to share my screen. And okay, is everyone happy that they can see the screen clearly?
Yeah, sure, we can.
Yes.
Okay, wonderful. So thank you, esteemed colleagues. As has been said, I'm Dr. Phumudzo Ndwambi, and it is an absolute great privilege for me to be giving this talk on such a forum this evening. And thank you for your time and taking the moment to share with me an experience of mine that I hold very dear to my heart. So as has been introduced, I am a general surgeon and I have a special interest in breast surgery. And I have then cultivated my niche to be that of oncoplastic breast surgery. So I'm very well aware that the audience is very vast and varying. And so I've tried to make my talk quite visual, quite practical. And as much as I'm so used to speaking to surgeons, I hope that it is appealing to a more global audience so that you guys can understand exactly what it is that I do. And you can maybe take this moment with me to walk a day or a week or a few hours in my shoes, which I find quite exciting. So I'm going to speak to you tonight about oncoplastic breast surgery in the South African context. So what is oncoplasty? And essentially, it's a combination of surgical oncology and plastic surgery. So in 1993, Dr. Outreach introduced the term oncoplastic surgery. And this was primarily because it had been evolving throughout Europe. And ever since the 1980s, many people worldwide had been making it quite popular. And so from about 1991 to about 2002, the rate of oncoplastic surgery started increasing from about 40% to 60%. And then the term extreme oncoplasty was coined. And then this was used to include patients who historically wouldn't necessarily have been included or deemed candidates of breast conserving surgery, but because they had tumors that were either larger than 50 millimeters in diameter or were either multicentric or multifocal. So for those of you who don't remember what those terms mean, I've taken the time to just do a little bit of a drawing. And so the first picture we have is an example of, in the red, we have what would be termed multifocal disease. So more than one breast tumor in one quadrant. And so this was historically known to be something that was an indication or an allowance for you to be able to do breast conserving surgery on a patient. And multicentricity, which is the blue dots, which is more than one lesion in multiple quadrants, that was historically deemed to be a contraindication to breast surgery. But if I put it to you that if you look at the second picture and you look at the red dots, which are by definition multifocal, which means more than one lesion in one quadrant, and you look at the blue dots, which are multicentric, more than one lesion in multiple quadrants, if you were to try and imagine yourself as a surgeon cutting out an area of the breast, surely it doesn't make sense that the red dots are allowed to be cut out by definition and the blue dots are contraindicated. And this is where, breast surgery and oncoplasty started taking a bit of a turn in terms of how we understood what we're doing in terms of breast conserving surgery. So breast conserving surgery. So for me personally, I am of the school of thought that every woman, even the one that has breast cancer, deserves to keep her breast. Obviously, that is not always, possible, and we'll go through the situations where we can't do that for a woman and what our options are. But ultimately, in this day and age, in 2023, having breast cancer should not mean that you lose your breast. So we are now focusing on the breast conserving surgery as a form of primary surgery, and we are looking at breast conserving surgery as a form of standard of care. And so when you start embarking on the journey of offering a patient breast conserving surgery, the first thing you must know is that it has to be followed by radiotherapy. And I'm sure somewhere in the audience, I have members of what would encompass my multidisciplinary team, which is normally a medical oncologist, a radiation oncologist, sometimes a plastic surgeon, and physiotherapists, dietitians, etc. But oncologists are a big part of how I do my job. And so if you're going to do breast conserving surgery, you have to be able to have the resources to provide radiotherapy. So for the surgeon, what we're trying to do is still keep to the principles of being safe, still keep to the principles of having an oncologically safe margin. So it's all good and well to have these pretty breasts, but at the end of the day, we have to understand that we're doing cancer surgery. And so you always remember for yourself that in cancer surgery, when you're operating as a surgeon, you're trying to aim for a 1 to 2 centimeter macroscopic margin. And the simple way to think of it is I mustn't see the tumor. When I'm cutting, I mustn't see the tumor. But once it goes off to pathology, we aim for an oncologically safe margin for invasive disease of 1 millimeters. In extreme oncoplasty, which is now those tumors which are larger than 5 centimeters, or those tumors which are in multiple quadrants, we still have to take into consideration those principles of oncoplastic surgery, which means an oncologically safe margin, but also it has to be aesthetically pleasing. So how do we assess? So what we need to look at is this woman a candidate for breast conserving surgery? Traditionally, breast conserving surgery was reserved for early stage breast cancer. So the people who came with very small lumps, stage 1, stage 2, 2 centimeter marble type lumps, and some patients came with ductal carcinoma in situ, or patients went off to their medical oncologist. They came back having shrunk a previously big tumor into a tumor that was less than 5 centimeters. That was what was previously the indication for breast conserving surgery. But now we flipped that script, right? And so now we have to look during the triple assessment that when you take your history, and this applies to everyone who comes into contact with that patient, surgeons, oncologists, GPs, etc., you have to be realistic with the patient in assessing, are they going to be a candidate for either breast conserving surgery as you look at them in your office currently, or potentially a future candidate for breast conserving surgery. That is something that must be assessed at the outset. And then you always involve your multidisciplinary team, which always includes the patient. So you have to speak to the patient about the realistic and feasible options to what they're going to be able to have, and then speak to the people who are going to be helping you as a surgeon. So your radiation oncologist, your medical oncologist, and importantly, your radiologist, because, you know, only radiologists have radiology eyes. And where I might be focused on where I think the tumor is in one place, a radiologist is able to tell me that, wait, there's a bit of a suspicious calculation on the other side of the breast, which might add a few curveballs to your surgery. So a multidisciplinary team is always important to include with the patient an honest conversation about what is feasible and what is safe. So we then decide, okay, the patient is either a candidate maybe for breast conserving surgery or not. And let's say they are, and we say to them, right, what else about you is going to influence what operation we do? And that comes into factors, the comorbid issues. And so comorbid issues always affect your wound dehiscence. Comorbid issues delay your wound healing. They cause sepsis. They may cause unattractive scarring, etc. And so a detailed history of the patient's comorbidities must be taken, and we have to elicit from that the fact that the patient has uncontrolled diabetes, the fact that the patient is smoking, they've got a high alcohol consumption intake, they've had previous surgery, and previously their wounds didn't heal as well as were expected, or they may even have formed keloids, or perhaps they've even had surgery on breasts. And now if a patient has had a previous breast reduction, years later they have a breast cancer, now you're trying to do another sort of breast reduction on top of a breast reduction. That comes into play the complexity of blood supply issues, scarring issues, and aesthetic issues. So the patient factors with regards to their history with surgeries and in regards to the control of their comorbidities is very important. And I know we sometimes are a bit too shy to talk to the fact that what is going to happen with regards to your surgery is going to be influenced by what is happening by your daily lifestyle. And I think we need to be honest with our patients about what that means. And later on in the presentation, I'll show you why not having this conversation can be quite disastrous. So if the patient has also had something like neoadjuvant chemotherapy or has had any history of immunosuppression, that also affects your wound healing. And so you have to factor in as a surgeon that the consent when you take it, and we'll go into that, must involve the fact that you're not going to heal like somebody playing on a field with a scratch whose platelets are working and the wound heals quickly. You're going to heal like somebody who's had immunosuppressive interruption, and everything that you thought was previously normal will stop being abnormal. Your skin is thinner, your blood supply is compromised, etc., etc. This is where consent comes in, because you're having a conversation and you're explaining to your patient, I'm going to do breast conserving surgery. Or even if you are not a surgeon and you're telling your patient, I'm going to send you to somebody who can do breast conserving surgery, or the patient tells you they want to do breast conserving surgery and you say, potentially you can't have breast conserving surgery because the risks of the complications are too high. And the big five with regards to the consent when it comes to consenting for breast conserving surgery are telling your patient about the potential occurrence of skin necrosis, the potential loss of the nipple and the loss of sensation of the nipple, the inability to breastfeed. And, you know, historically, this wasn't really a big thing with regards to cancers surgery, because people thought, well, I'm taking out your cancer, just be grateful. What breastfeeding should have nothing to do with it. Or it was just older women who had long finished their families, and so breastfeeding was not an issue. But we're now seeing more and more of younger patients, and by younger, I mean the under 40s, who haven't necessarily started their families, and who would still like to start their families, who would still like to breastfeed, who will ask you that if I have this operation, will I be able to breastfeed? I think honesty is probably the best thing to give them in terms of the fact that if you're able to breastfeed, potentially 20% of patients are able to breastfeed, but majority aren't able to breastfeed after a breast reduction surgery. You have to consent the patient that in oncoplastic surgery, the principles are primarily oncological, right? And so it's not a Hollywood type situation where you wanted to just come to the breast surgeon or a plastic surgeon and have breasts that you didn't like made into a way that you do like. This is oncological surgery that is now going to also have a component of reconstruction. It might not necessarily be the way you expect it to look. And so expect that the outcome that I have in my head as a surgeon as perfect and happy because my margins are correct and I'm happy that I got the cancer out, and you had another anticipation of these perfect breasts and we're not matching in terms of our expectations. That conversation must be had in terms of what is the potential unsatisfactory outcome that the patient might experience and what are we aiming for as a patient-surgeon experience. Then there is fat necrosis as a complication, and this complication is quite common because the breast is primarily made of fat, and when you have fat and the adjunct of heat, which is what we use when we use diathermy in surgery, and interruptions of blood supply and mobilization of the tissues, you may have fat necrosis. And so it's quite scary for a patient who's had previous breast cancer to then have a lump post the operation because they say, what is this? And it's just fat necrosis. It's benign. It's nothing to be concerned about, but it can cause anxiety for the patient. So it's something that you must warn the patients about before. So like I told you, if you don't talk to your patients and you don't have the conversation about the fact that, ma'am, sir, you're an uncontrolled diabetic, or your smoking is going to cause disasters, or you might lose your nipple because the size of your breasts are such that the distance from your sternal notch to your nipple is more than 40 centimeters and the blood supply will thus be compromised when I shorten it. Then when these complications occur, and unfortunately sometimes they do occur, your patient comes to you horrified. But not to scare patients away or not to scare anyone, but it is important to also be aware as a physician that obviously to the best of our ability, we absolutely work towards avoiding these complications. But a combination of a myriad of things may cause these complications. And so just for your encouragement to have the conversation, I've put these pictures up. So how I then assess what I'm about to do with oncoplastic surgery are the 6 S's. And so I take into consideration my site, so where the tumor is located, because generally, if you look at the breast of a woman, medially, which is closer towards the sternum, and superiorly in the quadrants, there's less volume, so the parenchyma of the breast is less there. So where there's a tumor there and you're trying to reconstruct, it's a little bit more difficult because you're more likely to experience or even see the defect in those areas. So you have to take into account that those areas are not as tolerant to volume loss. You have to look at the size of the patient's breast according to their bra size, primarily because a T2 lesion, which is defined as a 2 to 5 centimeter lesion in an A cup, is not the same as a 2 to 5 centimeter lesion in a G cup. And so you see a patient with almost no breast parenchyma, and she has basically a marble as a lesion. And you think to yourself, well, it's a small lesion. Surely they will be able to reconstruct the breast to still look like a breast. You have to consider the fact that given the volume of the breast in relation to the tumor size, we might not be able to have the outcome of an aesthetically pleasing breast. And so you have to consider what you can do with what the patient has. Excess skin and breastosis is always something to consider. Sometimes the tumor is in very close proximity to the skin. Historically, you were told that if the tumor involves the nipple areola complex, that's an absolute contraindication to breast conserving surgery. And I'll show you pictures later on that show that that is no longer true, but you have to then consider the proximity of that tumor to the skin, because where you create skin flaps and where you have remnant skin as part of your remnant breast tissue, and where you're trying to achieve an oncologically safe margin, you have to separate those two issues to say, sometimes I have to compromise the skin in this area and thinking other ways of how I'm going to replace that, rather than leaving it and compromising a potentially oncologically safe margin. Then the shape of the breast is important. Patients are always pedantic about this. Most of our population, South African population, have a larger than average breast size. So we get away with a lot of happy customers because, you know, we take them from very taut-thick, loose breasts to what are smaller and more compact breasts. So they're normally much happier with us in terms of the shape compared to their previous breast size. But also the location of the nipple is important. I did a case today, for example, where the patient's breasts were a bit too medial, and trying to move nipples that are historically medial to where they should be anatomically is basically magic. And so you have to sometimes explain to the patient that you're not a magician, firstly, and that if you are born with lateral nipples or very medial nipples, chances of you giving them these perfect central nipples are also going to be, you know, a give and take, and depending on how creative and how lucky you are in that situation. Symmetry is also very important, because when you're symmetrizing a patient with breast cancer, the one breast has a tumor, right? So you might have a breast that's big enough to have a reduction. So it's the reduction and the tumor, and the other side is reduced. But the fact that there's a tumor on the other side means that you will obviously take more volume on the other side than you would on the non-pathological side. And so the symmetry will never be the same. Luckily for us, no two breasts are ever made symmetrical, so patients generally understand this. But sometimes you have to explain this concept in the unilateral operation. And I'll explain to you situations where you don't do bilateral operations. And in the unilateral operation, you explain to the patient that I am taking breast tissue and bulk and tumor away from the one breast, so the breast won't look the same as it did previously, firstly, and it obviously definitely will look more asymmetrical than the other side. But our job as oncoplastic surgeons is to symmetrize the breast as best as possible, and so we give our patients the realistic expectation around that. And then also what's important is the substance. So the quality of the patient's breast, the density, the thickness, etc. And please make sure before you do any sort of surgery, even if it's not cancer, on breast, make sure the patient has had some sort of imaging before, because there might be things you're missing, small suspicious calcifications that you might not have sort of thought about before. So it's important to explain to your patient that if they previously had these very taut-thick breasts, you know, taut-thick breasts are as a consequence of the ligaments. You know, your ligaments are pulled, your Cooper's ligaments are pulling down. And so me as the breast surgeon, making your breast smaller or doing oncoplastic surgery isn't going to miraculously make your breast substance change. The density of the breast will be the same. The taut-thick nature of your breast will be the same. It just will look different in terms of shape and the reconstruction of where everything is now standing. But you must consider that as a breast surgeon, because breast density and breast tissue and the quality of the patient's skin is going to be important for your wound healing and ultimately the aesthetic outcome. So how do I approach oncoplastic surgery as a breast surgeon? Well, there's 3 types of situations that I normally encounter. I encounter a tumor that is less than 10% of the breast volume. So this has nothing to do with clinical staging. Like I previously mentioned, it's in relation to the size of the patient's breast. And so if you have a bigger breast, then 10% of your volume can still be a big tumor. If you have a smaller breast, then 10% of the volume, it could still be a small tumor. So in less than 10% of the volume that the tumor takes up, you do what is a wide local excision. There doesn't have to be any oncoplasty, which means you're just doing the surgical oncological approach. You're taking out the cancer with a wide local excision, making sure your margins are adequate and appropriate. And obviously you follow then with your lymphatic dissection or biopsy as is appropriate. That I've seen quite often, in situations where our patients are well versed in their breast cancer knowledge and they present early, or they have the ability to go for screening mammograms, and we pick up on things that may not necessarily have been palpable before. But what I have seen also is that the breast surgeon or the general surgeon won't necessarily take into account the aesthetic nature of the scar that they leave. And I implore that even with small tumors where we do wide local excisions, we need to be cognizant of the scar that we leave, because what you don't see if you don't follow up the patient for years to come, which is something a surgeon doesn't do, but the oncologist definitely does, is with radiation, with chemotherapy, with aging, with the droop, with the loss of elasticity and collagen, that breast changes shape and that defect starts to form and the breast starts to distort. And what was previously your beautiful operation in 2005 isn't so beautiful in 2023. Then there's what I love, which is what this talk is about, which is oncoplasty, which is now where the tumor takes between 10 to 20% of the breast volume. And this is where we put together level 1 oncoplasty. This is actually a lot of what I see in the private sector in my practice, such as the one at clinics, where patients are coming with small tumors, but they are, in relation to their breast volume, bigger than 10% of the total volume. And so you can't just cut the tumor out like you would a wide local excision. Like I told you, even the smallest tumor will leave a defect eventually. This one will definitely leave a defect that you will see in the immediate setting. Then there is level 2 oncoplasty, which is when the tumor is between 20 to 50% of the breast volume. That's where we do level 2 oncoplasty, and this is where extreme oncoplasty is included. This is where those patients who were historically excluded from breast conserving surgery are allowed to be a part of it, and this is where we normally use a bilateral approach in the operation to symmetrize the patient's breast, as well as do an oncologically safe operation. We do oncoplasty by doing 2 methods: volume displacement and volume replacement. And so I know I would normally do an operation in a level 1 oncoplasty, and I'm sure the oncologists are wondering why these incisions look like this, or what was she doing, what was going on. And it's primarily because outside of the fact that I have to remove this tumor, I'm cognizant of the fact that I have left a defect. I'm cognizant of the fact that as mobile as the breast is, it is attached to fascia. And so it's not going to move without looking distorted and concaved and aesthetically unappeasing. So I have to then mobilize my breast tissue so that that fat above the fascia is able to flop into and displace to fill that cavity that I've now created, such that the breast still looks whole and without a defect. And when you look to the other side, it may not be exactly the same size, but in terms of aesthetic looks, it looks the same. And that's what we mean by volume displacement. Sometimes the patient has smaller breasts, and even though they have a small tumor, you take it out, you leave a defect. No amount of volume displacement is going to compensate for your defect. So then you have to then look for other areas in the proximity of that breast to then have volume replacement. And that's when we use other pedicles to come and fill the defect that we've created with our type 1 oncoplasty. Here are some examples, and just as disclaimer, all of the pictures that I used are consented for this talk, but not for your own personal use. So please do not take these pictures for yourselves. These are pictures that belong to my patient and they've consented them for these talks. So here are some examples of some operations that I've done personally, just of the kind of things you can achieve. So I don't know if you can see my cursor, but essentially, this is a patient that historically would have been told, no, you cannot have breast conserving surgery because you have nipple involvement, because your tumor is so large that automatically when you meet me, I'm telling you you have breast cancer, and I'm also telling you that you're going to lose your breast. We send them to our wonderful friends at oncology. They give us some chemotherapy. This is what the patient comes back looking like. And so we have cyto-reduced our tumor. The nipple is still involved. We are not oblivious to that, but we're not scared. We're going to just do what we call a central segmentectomy, where we actually remove the nipple and the whole central segment of that breast as part of the operation, getting our oncologically safe margins, and then do a contralateral symmetrizing operation like we did here. So this woman is the same woman here. And as you can see, they're not perfectly the same size, but you can appreciate why they won't be the same size. I had a massive cancer to deal with there. But if you look at this and can imagine, the patient was extremely happy with the result that she was dealt with. These are some of the other areas that can be quite tricky in terms of finding volume loss. And so in these areas where there isn't very much breast tissue, but you have to do an oncologically safe procedure, which means going down to fascia, taking fascia, doing a wide local excision, you know that you're going to definitely leave a massive hole in this area. And in a woman with such small breasts, it's not going to not be visible. So as simple as the scar looks in its linearity, a volume displacement has been done so that some of the parenchyma from the medial section has flopped over to fill this area to not look like there's a massive hole that was taken from this area. Another patient who's had a medial tumor, quite large as well, where, like I told you earlier on, medial superior tumors, because the parenchyma is all down here, are very intolerant to volume loss. And so you do something called a medial segmentectomy. And in this woman, we later did a nipple realignment just to lift up. But you do a medial segmentectomy and you take out this entire tumor safely. You go down to fascia, you remove it, and then you mobilize the breast, and you do sort of, a form of a Z-plasty to mobilize the breast tissue such that this breast and this breast look exactly the same, despite the massive hole that you've left in this patient. And this is another patient that I've shown you, although a benign case, of a patient that will need symmetrization with a giant fibroadenoma, who essentially ends up needing a wise pattern reduction to be able to symmetrize her post-excision of her fibroadenoma. So knowing how to do oncoplastics is important. Another patient with a benign lesion who still also, despite her not having cancer, still will need symmetrization. So I just emphasize further the fact that oncoplasty, even if it's not necessarily for cancer, is important. Just to prove to you that this is not guesswork, all of these principles are accounted for by the fact that we have blood supplies in the breast, and we have certain pedicles. So the blue shading is the pedicles. We have certain pedicles that we use, that we mobilize up and down the breast to make our breast end up looking as beautiful as it is. And if you're going to be a surgeon doing breast surgery, you should be very aware of the blood supply to the different areas of the remnant breast that you're going to have and what you are severing in relation to the tumor that you're removing. This is just another example of a patient who historically would have been excluded from having breast conserving surgery because she would have had a large tumor. And so just to show you that, a woman like this ended up having breasts like that. Okay, I'm going to just go a bit faster now and tell you about the fact that, like I said, none of these things can happen without the radiation oncologists on board. And so radiation therapy is very, very essential in the adjuvant setting. And once you employ oncoplastic surgery, it gets a bit more complex because your application of the radiation to the tumor bed is not necessarily the same as what your incision lines are as the surgeon. So it's always important as a surgeon to put the clips of where the tumor was, because as I've shown you with my different operations and the different places where the incisions are, the radiation oncologist isn't able to guess where your tumor was in relation to where your incisions are. And it's also important to also have a conversation with them, which is why an MDT is always very much a necessity, to say, this is where the tumor was, this is what I've done, and help them try and understand your craft as a surgeon. Reconstruction is something that historically we were always encouraged to do as surgeons: remove the breast, call someone else to reconstruct. And so because now people think, oh, oncoplastic surgery is so complex, there's too many rules, I'm just going to do a mastectomy and send to a plastic surgeon. And I say that this should not be the standard of care, because don't be fooled into thinking that the plastic surgery reconstruction is less complicated than the oncoplastic operation or reconstruction done by the general surgeon. There are many more complex factors to include when you're doing reconstructions outside of oncoplasty, and you should be able to consider that when you feel deterred to doing oncoplastic surgery. When you are doing mastectomies hoping for a reconstruction, you must understand how you're going to involve tissue expanders. You must understand when this tissue expansion is going to happen. You must be able to have a conversation with your oncologist about radiation therapy, how it's going to influence or impact on your wound or your flaps, how chemotherapy is going to affect the wounds and the flaps. The sequence and the timing around all of it is very important. And so if you can keep a patient's breast, do a one-time operation, because we're now in the era of doing this. Rather do that if you have the skill set, or obviously send to someone who does. This is just an example of reconstructive surgery done by autologous reconstruction, where you've had bilateral mastectomies. They are non-nipple sparing, but they're skin sparing. And when things go great, they go really great. The woman in the first picture, great result. She had DIEP flaps, so they came from her abdomen, and she looks wonderful. The woman in the second picture, obviously, given the fact that she's obese and probably has other comorbidities, but when things go wrong, they go spectacularly wrong. So don't even think you are now exempt from being part of the consequence of what will happen to your patient in the reconstructive phase because you've just decided to do a mastectomy. Psychology is obviously important, and I'm sure a lot of our GP and our oncology colleagues can tell you about what it means to break the news to a woman that the result came back as breast cancer. She now has to deal with the fact that what's going to happen to my breast, and it automatically goes to the surgeon and what we're going to do to that woman. And what we do to that woman as breast surgeons is what remains with that woman. You know, when you have a mound that is insensate and doesn't look like a breast, even though it looks like a breast on top of clothes, it still reminds you that you have breast cancer, as opposed to when you have something that still looks like a breast, is reconstructed with a nipple, has remnant sensation. You still have that moment to feel like an empowered woman who has beat breast cancer. So this is just another reason to include oncoplasty as part of our practice, because it has a lot of psychological impact and in the advantage for those who practice oncoplasty. And obviously, all the other foreign bodies that are involved in reconstruction also have their own complications, and you obviously take that away from the patient as well as the expense if you know how to do oncoplastic surgery. So I know I termed this talk in the South African context, and it's because, you know, we're not a country that is very much about plastic surgery and how we look and so on and so forth. But I think we're becoming more and more global citizens, and the world is coming to think in a more bottleneck fashion. And so we have to think of our patients in the global context now. And so the training of general surgeons should always now be emphasized with regards to oncoplastic surgery. And that's not necessarily true in all the centers of general surgery where people are trained in this country, but there are quite a few centers that have oncoplastic surgeons who are training their registrars who end up being specialists who are trained in oncoplastic surgery. But for all intents and purposes, all breast cancer surgery should be viewed as oncoplastics. And like I said, please always include your multidisciplinary team. And just because you are a general surgeon who knows how to do oncoplastic surgery doesn't mean you no longer need to know a plastic surgeon. The plastic surgeon is still very much a part of the team. And even if it's just for the basis of doing your contralateral operation, symmetrization, or giving you advice and tips and tricks, have a plastic surgeon on board. They're very helpful. And obviously this is their specialty, so they can really be useful in helping you also upskill yourself. So I think I've basically emphasized all of this. It's important for us to all be involved in doing oncoplastic surgery. Plastic surgeons should learn oncological surgery. Surgical oncologists should learn plastic surgery. And together, as the evidence shows, we improve the quality of outcome when we put together that oncology and that plastic surgery to give our patients the best outcome. I'm just going to skip through this just because in the interest of time, I think I might be going a bit too long. But essentially, the need for extreme oncoplasty in South Africa is highlighted because our patients present late sometimes, and sometimes they present to us with locally advanced breast cancers. And most people historically have been taught that automatically that means mastectomy. So this is just a reminder that there is this, new kid, not so new, but adjunct called extreme oncoplasty. We can still do breast conserving surgery with the skill set of a trained breast surgeon with an oncologist and radiation oncologist, medical oncologist on board, with the go-ahead from the radiologist telling you that all your other quadrants are clear, to provide women with that reconstruction that is aesthetically pleasing and still the original breast, but it's not always possible. And so obviously things such as outreach and awareness and things to bring our patients earlier, screening, etc., are important. But the emphasis on this was just to talk about the fact that we also just need to start offering our patients what is globally acceptable, what is happening in the rest of the world. Don't be limited by our resources and what we know or don't know to what we can offer our patients. And I think it's probably encouraging to people in the primary healthcare sector to say, actually, I know breast surgeons are doing great things out there, and don't be distressed about automatically losing your breast. That means that there have to be clear guidelines, clear protocols. Don't sell people dreams, and don't sell unrealistic expectations as well, but understand what a patient that can have extreme oncoplasty is like, and one that will have mastectomies, and what those options are, which I'll touch on briefly just now. Okay, so I'm going to just skip over this, but basically it just talks to the fact that I know a lot of people are always asked, oh, but if I keep my breast, does that mean that the cancer will come back, as opposed to if I remove my whole breast? Some people are just like, take it off, because they just think this is the factory that makes the breast cancer. My body is rebelling against me. Take the thing off. And it has been shown that with the adjuvant radiation, breast conserving surgery is equivalent to a total mastectomy in terms of recurrence rates. So if your patient has the resources to get radiation therapy and they can have breast conserving surgery, then the recurrence rates are equivocal to a mastectomy. So having a mastectomy doesn't mean you won't have a recurrence, and doesn't mean that you are safer than the patient with breast conserving surgery with radiotherapy. Okay, so my little selling point about the fact that oncoplasty is here to stay, I encourage that general surgeons go and learn about it. You make friends with your plastic surgery colleagues, and everyone else in our community, our colleagues, just be able to speak to your patients about the fact that we're no longer just severing breasts of women. We are getting to the point where we believe women should be able to keep their breasts, and where they can't, we have alternatives, and those are reconstructions like we historically know. I'm just going to quickly touch on what happens when you don't save the breast, just because I know that there are some surgeons who are very well versed in doing mastectomies, and that's what they've been taught. And so if you're going to be doing mastectomies, please at least make them look pretty, because even the mastectomy is meant to be oncoplastic. So it's meant to be oncologically safe, as well as looking like it has an aesthetically pleasing outcome. And so this is just to say that by definition, according to the National Cancer Institute, having an aesthetic flat closure is no longer a privilege. It is now your right as a patient. And so this came from the fact that many women came back years after their mastectomy. They've had their adjuvant therapy, chemo, radiation, etc. And now they're stuck with this horrendous operation that they've had, because rightfully so, the surgeon was just trying to get rid of the cancer, but now the outcome didn't look so pretty. And so this is what happens when you're not cognizant of what it can look like if you're just looking at taking out the cancer. And so these are examples of some mastectomies which can go very, very wrong, with thick flaps, with dog ears, with pleating, and just asymmetry, etc., etc. And so ultimately, what's the dream is this. You want to have flat closures, a woman that if she's going to not have a breast, what is left behind is flat, so that if she puts on a top breast, so a silicone or with a sock even, it still is on a flat surface. Or if we're going to do a delayed reconstruction, we're doing it in the setting of having had no remnant breast tissue or minimal remnant breast tissue. This obviously means that as a general surgeon, you need to preoperatively mark your patient, understanding their body habitus, etc., so that you achieve this outcome. This is what we're trying to avoid, because if you're not careful, if you're just focused on the oncological part of the operation and not the plastic and reconstructive part of the operation, you're going to have thick flaps. You're going to have flaps that are too thin, and they're going to necrose. And this is what happens. Like in this picture, you're going to have medial dog ears. Like in this picture, you're going to have horrendous lateral dog ears, like in this picture. And so I'm not going to go into this because this is more of a surgical experience, but just to show that there are techniques where you draw and you make your mastectomy scars look beautiful, as well as circumventing those dog ears, those thick flaps, those thin flaps, by understanding the different mechanisms we employ to get our aesthetic flat closure. And this is a very small framed woman, but here's what happens in a bigger framed woman, where you add an extra step, where you deepithelialize her lateral fat and cover it up, still to get that beautiful aesthetic flat closure. And then this is just for people who don't know just what we can do when you times in our setting, we have medical tourists who come, and they've come from wherever they've come from in neighboring countries, not having found the help they need, and they come to us looking like this, and you think, obviously with the neoadjuvant systemic therapy that our oncologists provide for us, there are things that we can do which are still oncologically safe, and we can still do what is called in this situation a thoracoepigastric flap, and have, this is the same woman, have an aesthetically pleasing outcome, safe oncological margins, and that woman, for all intents and purposes, was cancer-free at the time. This is just another slide just to show you the kind of weird and wonderful things that I do, just to tell you that breast pathology isn't only cancer, it is a variety of things. This woman had PASH, also known as pseudoangiomatous stromal hyperplasia. She was, you can see how small frame she is, unable to bathe herself, unable to do activities of daily living. And you can imagine that the operation we did to reduce her breasts was life-changing. A woman in the second picture with a phylloides tumor, she obviously had to have a mastectomy. Plastics was on board. Were unable to close it. It left a defect. They came and did a flap once we knew we had our margins. that woman was a pregnant woman, if you can notice the pregnant belly, who had then also had PASH, and we had to do a mastectomy for her because it was the safest operation given her pregnant status. Also life-changing surgery when you're encountered with things that are not just cancer things. And then lastly, just to close off, something that we all encounter at some point from our internship days, student days, to now is a breast abscess. And I just want to tell you the story of one of my patients who presented to a local clinic. She is a 28-year-old girl. I'm sure now she's 29, but she was 28 at the time, and she had a 2-year-old, and she was still breastfeeding. So she gave that as part of the history. And so everyone was like, okay, lactational breast abscess, young patient. And they did an IND. And so she then came to my breast clinic, and the first week I saw her, it looked like an IND of a breast abscess. Somebody who had cut into breast abscess, it was healing. I said, wonderful, it's going to heal beautifully. I'll see you in 2 weeks' time, when I expect it to be fully healed. 2 weeks' time, she came looking like this. And this is when we thought, this was not an abscess. It never was. And so triple assessment, we put that into gear, and we diagnosed her with a triple negative breast cancer. And this is where I say the beauty of an MDT, and thank goodness I have those colleagues in my sphere. We spoke to our friends at radiation oncology and said, colleagues, we don't know what to do with this. We can't do anything with this as surgeons. Please help us with some preoperative radiation therapy to see if this will even get to operation stage. Our radiation oncology friends gave us some radiation, and you can see the side effects of radiation, but you can see also the miracle of radiation. And they gave us some radiation, and this is what it looked like after radiation. And then we spoke to our friends at medical oncology and said, please give this lovely young lady her neoadjuvant chemotherapy. And they did that for us. And she came back looking like this. And obviously, the minute she came back, we remembered this girl, and off came the breast. So this picture, unfortunately, is a picture when she was still, like, I think the next day. So she's still a bit swollen. It now looks very nice and flat. But we took that breast off, and she's still doing very, very well. And, you know, it's one of those stories that look very scary and make you despondent in the beginning. But if you know that there are pathways to follow, and if you know that there are things that we can do as a breast MDT, then you know that we can get these women to a quality of life that is good and that has great outcomes, despite what the initial presentation may look like. And that is all from me.
Wow, thank you very much. What a happy ending. Yeah, what could have been a bad situation was saved for this case that you've just shared with us. You know, sometimes when you go to a meeting and you listen to a story of, it doesn't not sound like a medical discussion. It looks like something, testimony about how something wonderful happened when I had a problem. And that's how it sounds like. And I can feel the passion and the energy as you speak about what you do. And it shows that you truly love what you do. And it's good
Absolutely.
to see it coming out from clinicians and a surgeon like you. Saying that you've been talking to two groups of people, talking to your colleagues, the general surgeons, and then to all of us. Yes, even patients also, to say that, I think the old school, just before the times of oncoplastic surgery, what is the uptake of colleagues who might have trained much earlier than yourself, who are complete, good, excellent, efficient general surgeons who know that breast lump, you do your SLC, and then if it's a cancer, if you can salvage, you do a tumor mastectomy. How likely are they to get into this new way of doing things, oncoplastic surgery? How amenable are they to? Because are they referring or learning
So I found it interesting. I've given a lot of these talks quite often because, as you've said, it's my passion. And I do have quite a few of our older colleagues who are here to hear about it and learn about it. And the thing about the older school generation is that they've have enough experience to also know their limitations and to know where things that they can do are possible and not. And so they do refer where they can't. And they, as clinicians, we should always be people who are always keen to learn the next thing and always keen to upskill, no matter our age or no matter our years in the profession. And so that's why I don't believe in like harboring the information to myself and being like, send everyone to me, I'm going to do it. It's about, telling you that it's out there, go learn about it if you can. If it's not for you, it's not for you, and you can send it to me. So the response is both. People are very much like, this is not for me, I'm sending to you, or, oh my gosh, please tell me more. And so it's both. And our older colleagues have been very receptive to it.
Yeah. And I think the other group of clinicians is the plastic surgeons.
Yes.
And I say that oncoplastic surgery do a little bit of what the plastic surgeons will be doing. But also working together has been a good experience. Because I know some centers where you had a plastic surgeon and a breast surgeon working together, and the breast surgeon will do what they can do, then hand over to the plastic surgeon. But now you tend to say that you'll be able to do what the plastic surgeon could do first time with your patient, just you said,
Yes, there are actually papers written about the back and forth tussle between the breast surgeon and the plastic surgeon, and ultimately the consensus is, and when I went to Scotland earlier on this year, the breast surgeons there, they do plastic surgery, so they put in their own implants, they do their own liposuction and fat grafting, and whatever is breast related, a breast surgeon is allowed to do. There's no taboo, there's no controversy. In this country, it isn't practiced that way because general surgeons are meant to do oncology, plastic surgeons do reconstruction. The way that historically we've been trained, you book your case, you call the plastic surgeons, they must know your case is happening, and you work as a team, which I still encourage, of course. But it's to say that it's not that the plastic surgeon mustn't do the oncology operation or that the breast surgery mustn't do the reconstruction. Both should upskill themselves to do both, and it is always better to work in a team. So even me with all my skill set, I still call my plastic surgeon to come and work with me, even if he's doing or she's doing the non-pathological side and I'm doing my reconstruction and my cancer operation on the pathological side. So it's not someone taking someone else's specialty. It's why don't we just learn both? There's no harm in learning both.
Yeah. Maybe last question, my side, taking this oncoplastic side. In terms of training, the different centers that you mentioned, are the current surgeons, the heads of departments, are they keen on including oncoplastic surgery in the training of registrars who are doing general surgery?
So yes, I mentioned them because they all are oncoplastic surgeons. And there's databases. It's mainly Gauteng, KZN, and Gauteng is Pretoria and Joburg. In KZN, and then we have the Western Cape, which is Stellenbosch and Cape Town, where they have trained oncoplastic surgeons. The other centers, there are oncoplastic surgeons upcoming. Not so sure how the training is, but everyone is upskilling themselves. But I know that those 4 centers, because they've published and because we, as oncoplastic centers, I work at Barra as well, and we're an oncoplastic center, we work together to formulate a syllabus and workshops and courses around oncoplastic surgery. We're even currently developing an MPhil in breast surgery around this specific topic. So this is why I mentioned those ones from an academic point of view.
Okay, no, thank you very much. One of the questions that we find on the chat box there, I think at the beginning when you were explaining about tumors and so on, you spoke about necrosis. Perhaps just in terms of what you find in the diagnosis and histopathology, or in terms of necrosis, maybe just take us a little bit through that process or your findings about tumors that become necrotic and what it means.
So So as in a biopsy that shows tumor necrosis.
Yeah, it's an open-ended question about necrosis generally.
Of the breast lesion or of the breast fat?
Yeah.
I'm not understanding.
Both the breast lesion or the breast, because you spoke about one of the colleagues
Okay.
here wants to talk about necrosis.
I'm just going to speak globally about it. So there's fat necrosis, right? Fat necrosis as a consequence of trauma, potentially as a consequence of aging and involution of the breast. And so with the changing age, with changes in the fact that trauma might have happened, with hormonal status changes, including pregnancy, including being from childbearing age, and then deciding you want no more children, having exogenous hormones involved, all of those causes involutional changes may cause necrosis. With regards to cancers, right, there are biopsies that show that there is necrosis as part of the histopathological diagnosis of cancers. That just talks to the place where the core biopsy was taken, and obviously it's central where the biopsy was taken, and we'd rather do a repeat biopsy, which rather tells us more about the biology of the tumor, so more peripheral, etc. But fat necrosis of the breast is involutional, is part of the breast. It can be trauma-related. It's a case of reassuring the patient. If I'm talking about benign situations, reassuring the patient, massage, and things like that, as well as analgesia are what I would use to treat it. I'm hoping I've understood the question correctly.
Yeah, hopefully, yeah. Because it means it's just tissue that will die off and might regrow again.
No, it won't regrow.
Yeah.
What I always say, this is how I say to my patients, it's like, when you have those sticks of butter or those sticks of like fat, and then you heat them up, and then the fat changes in its formation to oil, and then it reconfigures. It won't ever look like that stick of butter again. It may reconfigure to be, but it won't ever be. So it won't regrow, no.
Okay.
Yeah.
Thank you very much. Yeah. Next question is the histological type of tumor influence in oncoplastic surgery. Does that have any influence, the type of histology on oncoplastic surgery, whether you've got different types of tumors? Does it influence whether you're going to do any type of oncoplastic surgery or not?
So part of taking the candidacy of a patient to whether they can have breast conserving surgery or not is based on all the factors. So how aggressive the tumor is, their comorbidities, and what the patient and the tumor biology, as well as the breast parenchyma, are looking like. So in a patient with an inflammatory breast cancer, so the historical T4Ds, there's no place for oncoplastic surgery. Those tumors are in their nature, but when you look at it, it looks like a massive grapefruit. There's no place for oncoplastic surgery. It involves lymphatics. It involves dermal vessels. That's where that peur d'orange comes in. Off comes the breast. No place for breast conserving surgery. But like I told you, a mastectomy can still be oncoplastic by being beautiful and flat in its nature. All the other clinical stages of breast cancer in the MDT we discuss with the radiologist. Is this in the area where we can cut it out safely? There's nothing else in the breast. Radiologist gives you the thumbs up. Medical oncologist, you say, and radiation oncologist, we look at it and say, the biology of this tumor, is it grade 3? Is this an under 40 patient with a KI of 90%? KI is the proliferative index at which this tumor is, proliferating. Is it a patient that, like that first patient that I showed you the picture of, where it was an abscess, it mushroomed? There's no place for oncoplastic surgery, even though that chemo and that radiation did a beautiful job of shrinking and making it look like, oh, now we can do oncoplastic surgery. That is a patient where you say, no, we remember what it looked like before. Off comes the breast. So you have to take the whole story into context and discuss with your radiation and medical oncologist, as well as your radiologist. And I always say, don't forget how the cancer presented. Like that last picture I showed you, we thought it was an abscess. That presentation is so easy to get excited and be like, but look what she looked like in the end. And she's young. Of course, she wants to have her breast saved. She's recently gotten married even with her breast off, but it's because we said the prognosis with what we had is there's no place for oncoplasty for her outside of a flat closure.
Yeah. And Phumudzo says, as an onco patient that will undergo surgery post-chemo, those pictures were scary. It's like you're watching a horror movie.
Yeah.
How do you manage this patient to say, this is what you look like, we're going to do this intervention, but this is how it's going to look like?
So ultimately, and the beauty of an MDT is having people that you know, right? And the people that I work with in the clinics group are people that I know that their counseling temperament and their personalities are such that they've spoken to the patient. You know, when you've diagnosed with cancer, you don't hear everything all the time. You need to repeat it about 20 times before it sinks in, right? And that's why I take video diaries, because you have to remind the patient the journey that they've come from. Because from seeing, for example, Dr. Chabalala, who does medical oncology, to seeing Dr. Ndwambi, who does the surgery, there's a 6-month in between, you know, and the patient sometimes forgets and gets excited, and you have to remind them, or things get worse, you know, and you still have to remind them that we're still here, we're still part of the team, and there's always a plan. And I think constant communication, constant counseling, realistic conversations, honest conversations, and having a relationship with your MDT where you're saying the same things to the patient and not one selling dreams, one selling, you know, death, or vice versa, is important. And so I think having that MDT where everyone is on board with the patient involved is always the game changer.
And it always includes a psychiatrist or psychologist.
Always includes a psychologist. I mean, once you get to the psychiatrist, and you know, psychology mustn't just be for the patient, because sometimes the patient goes through the journey psychologically, they're, you know, at a deficit, and then they go through and they get better, and they're happy and healthy. And then after everything, then the family then only speaks up to say, we were so scared for a whole year that you were going to die or whatever. And so, yes, psychology is important, not just for the patient, but for the family as a whole. So generally, the oncologists or myself, sometimes even the radiologists, have to break the news. And it's always good to have them come with a member of the family and next of kin. The more the merrier, because everyone will pick up one sentence. Not everyone is hearing everything. It sounds like a blur. And so psychology then becomes the next point of call, because, you know, we can't be trained at everything.
Yeah. Now, last question. You showed us a picture of a patient who was pregnant, but there is a question with pregnancy. Now, if you diagnose cancer, breast cancer, in early pregnancy, what approach do you take? Do you advocate for neoadjuvant therapy or surgical therapy? What's your approach?
This happens to me actually a lot more often than I would like to, but again, thank goodness for the MDT. And this is where our friends from OBS and Gynae come in. Pregnancy-associated breast cancer, when diagnosed in the first trimester, is probably the most devastating, especially if it's a precious pregnancy, because there could be the fact that you have an operation, you could have an early breast cancer, which means you can have an operation that has to be a mastectomy. Why I say it has to be a mastectomy is because having an operation in the first trimester has its own complications with regards to anesthetic risk, right? It's not that anesthesia causes miscarriage or anything like that, but we all know there's risks with surgery and pregnancy in the first trimester. You have your mastectomy because if you don't have your mastectomy and you have breast conserving surgery, you have to have radiation therapy. And pregnancy is a long time. And so you won't be able to have that radiation therapy because you'll be pregnant. Because I'll do the operation today and your pregnancy is still going on for 9 months. And we're trying to give you your radiation therapy timelessly for it to be effective, which is between 6 to 8 weeks. You can't give it afterwards, you know, wound healing sometimes delays it, etc., etc. But we're trying to give you timeless radiation therapy or adjuvant therapy, given the fact that also being pregnant, if you are a hormone receptor positive breast cancer, it's pumping those hormones and it makes it more aggressive. So those patients get very aggressive breast cancers as well. If they're in the second trimester, right? That's where we have a lot more leeway to say, let's see if you would like to follow this pregnancy through, how we can help you and get you to the point of monitoring you and making sure that to the best of our ability. Obviously, now you're treatment naive from a chemotherapeutic point of view. We'll watch you, and then we'll lead you to the final trimester where you can start having chemotherapy once development of baby is safe, and our oncologists and our gynaes and obstetricians talk together about when to induce the pregnancy, the timing of chemo, the timing of delivery, etc., etc. But there have been breast cancer patients who are pregnant, who have delivered safely, who have been on chemo. But the first trimester ones are the tricky ones, because that's when all of the teratogenic effects happen with chemotherapy.
Yeah. Can I go back to this example that you ended up with, the INT, the abscess case?
Yes.
Just for clarity, maybe when they did the IND, and should they have done it, at least when they did they thought an abscess and take the sample for MCNS?
So the MCNS,
you still miss the cancer even if you do the MCNS.
The MCNS sample came back. We followed it up. It was just sensitive to cloxacillin, just neutrophils, the usual, scanty, blah, blah, blah. There was nothing special about the MCNS. And we don't conventionally talk about taking a biopsy in lactational breast abscess because they are common. We rather encourage, if a breast abscess is non-lactational, take a biopsy because you might be missing a cancer. There is a MMed that was recently done that speaks to not even taking a biopsy on non-lactational breast cancers, because the turnover of what ends up becoming cancer from abscesses is so low that why take a biopsy? But this is what happens when you cut into things that look like abscesses. This is one of those situations that are forgivable. Her age, her being breastfeeding and having been recently pregnant, I think most of us would have probably just treated it like a breast abscess. You can't blame anyone for it, but it's just to show you about what cancer can do if it's hiding, and just to make you aware that more and more in this current age, younger and younger patients are having breast cancers, and they are very aggressive.
Yeah. Thank you very much. I'm going to ask Dr. Kinoshi just to do some remarks before we close. We'll close the remarks and then we will wrap up. Dr. Kinoshi is the Chief of Operations. You might have met him, I don't know.
Thank you very much, Dr. Bila. And thank you very much, Dr. Ndwambi. I think I'm so impressed, with your lecture, which is so informative and so eloquently and passionately delivered. I think you obviously love what you do, and I think you are on to a good one, because I think, as you say, cancers are becoming more and more frequently seen, but also we're getting younger and younger. When we grew up and when I was at medical school, we knew cancer to be of older people and for a certain type of, but now it's becoming more and more common amongst young people. Even cancers which were not common amongst our people are now common, probably because of lifestyle, for many reasons, what we eat and drink. So we don't know, but I think we need more and more people like yourself who do this thing. And I like the way you came up with a topic that is not, that might be new to some of our colleagues, oncoplastic surgery. And I think it challenges also other doctors and specialists who are listening. I think today we had almost 240 people in the room listening to you today. And I see Dr. Bila, there's still a hand, there's still a question coming. So maybe after I've spoken, I'll hand over to you to take the hand that is there. But let me just finish what I'm saying. I'll just conclude and then I'll hand over back to you. The way you delivered it, it could have challenged other specialists also to come up and share their expertise, and whether they agree with you or we've got other ideas. Most people, the way you spoke so convincingly, would definitely agree with what you're doing. I'm glad that we have this expertise even within clinics health group, and so people would know that we provide only the best care in clinics for our people, and you make these procedures available to the people near where they stay. But also, let me thank also the loyal audience that week after week log in to learn. I don't think they log in only to score HPCSA CPD points for HPCSA registration, which they also do get as well, Dr. Ndwambi. But they log in to get information and to learn new things in this honorable profession that we are in medicine. And I think most of us, include myself in here, I've gained a lot from your lecture. It was indeed a lecture, and I think we have recorded it, Dr. Bila, so I'm sure it will be available also on YouTube, as you know, for those who could have missed it. But also, without the audience, we would have stopped. Dr. Bila said that we've been at it now for 2.5 years now, since 2020, with these weekly webinars. And I think we're doing well. We're saving not only our patients spreading knowledge, but also our own doctors. We have GP specialists, your colleagues, and many others who log in, but also other professionals as well. You spoke about MDTs, multidisciplinary teams, and I see quite a number of people from other allied professions had logged in as well. But I should thank the clinics board, the board of clinics, for allowing us to continue with these webinars. Normally, when we started, it was because they were replacing our CME meetings, which we had roughly once a month or so in our institutions before COVID. But during COVID, when we couldn't meet during lockdown, this thing, the various stages, we then thought about in starting with the webinars, and here we are. We're continuing even long beyond COVID. But as long as colleagues continue to log in week after week, we will continue with the webinars. Once you stop, obviously, the webinars will die. So the webinars are there. You are maintaining the tempo, and the board and the group CEO, Dr. Matseke, as well as our marketing team that works in the background and to ensure that technically everything goes well. They support our webinar master, Dr. Bila, who does this so wonderfully week after week. Thank you, Dr. Bila. But thanks, and let me hand over to you also, Dr. Bila, to take whatever question there might be and also do the closing. Thank you very much.
Thank you very much, Dr. Kinoshina. Thanks for the support and for the group, the board and the EXCO allowing us to continue with these webinars. And to Dr. Ndwambi, just to indicate that I just shared your details with our Professor Carol Ben, who you should have known, one of the pioneers in breast surgery. She's quite impressed and quite happy to see younger generation joining in. And she'll be contacting you because there's some projects they want to do in breast cancer awareness. As this is a breast awareness month, we thought we should have this discussion tonight. But also we also having a mental health awareness month, and so we'll be continuing next week with discussions on mental wellness. We have a neuropsychologist who will be talking to us next week, and the other week we'll be talking about trauma-related illnesses in mental health. So we just want to thank everyone, Dr. Kinoshi Kamwe, and everyone who has joined us in. We hope to see you again next week when we continue our webinars. And have a good night.
Thank you so much.
Thank you, and good night all.
Thank you, good night all.